these are the typical pictures you get on the scans. A young patients, good cartilage. You see the meniscus is extruded on those coronal slices, and at the back you'll see the little root tear where it's pulled out. Often get very subtle little pieces, a little bit of bone edema at the posteromedial tibial plateau. They should all point you to look for root tears. If you get your axial slices and you get the right slice, you can often see it on that, the vertical tear through the meniscal root, and you get the typical ghost sign on the sagittal views as well. So in a young patient, you want to be thinking about getting in early and trying to repair those back down. This is work from Robbo, where he looked at the strength of the repair. So you get the root ligament, you put it through a transitional zone or in the body, and there was a marked increase in strength of your repair if you got your stitch into the body of the meniscus rather than the root ligament. So that's where, for years, we were trying to aim towards. So this is a typical case. This was a medial meniscus root in a young patient who's a footballer. And even if you get it within a couple of weeks, there's always attempts at healing. And if you leave it too long, it will look like it's healed despite being extruded. So you've often got to debride some of that scar tissue that forms. What I always then do is grab the meniscus, see if you can reduce it back down to where it's come from. So you see this one's just a little bit tight still. So it's not pulling down to where you want the footprint. You've got to release around the back, and it often just forms a bit of scar tissue. So we just take the radio frequency. You can see the scar tissue there. Just release that to allow the meniscus to reduce back to where it came from. And now we mobilise that, and we can see that it reduces nicely. So I know now, if I put my footprint in, I can reduce the meniscus back down. So always the first step. So this is how I used to do them long time. This was in the cadaveric lab. So we artificially made a tear. And the majority of these devices now fire a needle from bottom to top. So again, you check mobility, you find your footprint. Important to just decorticate the area to make bleeding cancellous bone. Drill your wire up, then over-ream with a 4.5. And then you just create a passing suture to come through there, which you can retrieve through the portal. So that's a fairly generic tunnel position for that. But really, in terms of the meniscal repair work, it's often done, and each company has different devices, bottom to top, and you fire a suture up or tape, whatever you want to use. But you've got to be going into the body to get the strength. If you try and do it too near the root, when you pull, it will just rip through because the collagen fibers are all lined up that way. And for me, when I was doing this, it was always just slightly pull in the wrong direction. So we then changed technique. So this is the standard technique, which is a vertical stitch. But when you pull on that, you are at risk of pulling it through the collagen fibers. So what I've changed to maybe 2 or 3 years ago now is just using a vertical stitch. We go down, we come forwards and drill back, put the stitch back up again. So you get this vertical loop perpendicular to the collagen fibers. And when you pull on that, it ain't coming out. So you can put this pretty near to where the avulsion site is, and it's not going to pull out. And that means when you pull it down, you're pulling the bit you want down into your root prep. So this is what I use. This is Smith Nephew NovoStitch. The bottom jaw is retractable. In the bottom picture, it fires a needle up, which goes through the meniscus, hits the black, and then exits forward, so you're not going to be at risk of damaging cartilage on the femoral condyle. So this is just an example of it. So we've got the first stitch in, just to hold it as an anchor. So you can see it's very low profile. We release the jaw underneath, and then you can just release the tension on the meniscus. You just wriggle that bottom jaw underneath, and this is 2 bites. So we start at the back of the meniscus. We're going to bite, come forward, bite, and then that's it done. So it takes about 10 seconds. You've got to squeeze fairly hard because it can be quite a thick meniscus at the back. You come forward slightly, take a second bite, and that's giving you a vertical loop underneath the meniscus. When you pull on the strings, you can shuttle those down. I've got a second one coming, you'll see it's slightly clearer. You can shuttle those down, and when you pull on that, because the sutures exit superiorly, they pull the meniscus down into your tunnel rather than having an inferior one. So the second bite here, we go just behind, take 1 bite, and the needle exits forward, not upwards. Come anterior slightly, that makes our loop. Do the second bite, and you should hopefully see the little loop on this one. So when you pull on that, you'll see the loop underneath, and that's in a vertical orientation. And when you shuttle these down, they're coming out the top, and they pull the meniscus down nicely into your root. And I think gives you a nice coverage, and it pushes down into that cancellous bone. Then you do the usual, pretend you're pulling on it really hard, just for the video. So the rest of the kit we use, I mean, it's all the curette's really important. It's got a nice angle on it. It decorticates nicely. There's a left and right curve for the aimers. And it's not left and right knee. It's just you pick which one fits in best. And I've found, certainly for the roots now, even a medial meniscal root, it's probably best accessed for making an incision on the lateral side of the knee joint. But each company has its own. They've all got variations of the same thing. That's Comrades as well. They've all got their own ways of getting root repairs done. And what we thought was useful to do, we did this a couple of years ago for Tim's meeting. So whichever company you use does have a system that you can use. And if you haven't got X company, you can use a different companies, but there's lots of different ways. But I think if you get one of these root repairs, particularly a young patient, I would highly recommend trying to repair them down.